Hi, I'm Dr. Maria Corcoran from the University of Washington. In this Hepatitis C online mini lecture, I will be discussing some key studies supporting the safety and efficacy of sofosbuvir-velpatasvir for the treatment of hepatitis C. I'd first like to provide some background on sofosbuvir-velpatasvir and outline the standard dosing for this drug. Sofosbuvir-velpatasvir was approved by the U.S. FDA on June 28, 2016, for the treatment of patients with chronic hepatitis C and genotypes 1 through 6. It is indicated for use in a wide variety of patients, including those without cirrhosis, those with compensated cirrhosis, and those with decompensated cirrhosis. Sofosbuvir-velpatasvir is co-formulated into a single tablet that contains 400 milligrams of the NS5B polymerase inhibitor sofosbuvir paired with 100 milligrams of the NS5A inhibitor velpatasvir. It is dosed once daily and can be taken with or without food. Adverse effects are mild and include headache and fatigue. In patients without cirrhosis or with compensated cirrhosis, sofosbuvir-velpatasvir is given for 12 weeks. Of note, patients with compensated cirrhosis and genotype 3 require baseline NS5A resistance-associated substitution testing. Those without a Y93H mutation can be treated with 12 weeks of sofosbuvir-velpatasvir. If a Y93H is present, then ribavirin should be added to sofosbuvir-velpatasvir or another direct-acting antiviral should be used. For patients with decompensated cirrhosis, the recommendation is to give sofosbuvir-velpatasvir plus weight-based ribavirin for 12 weeks. For patients who are ribavirin ineligible, 24 weeks of sofosbuvir-velpatasvir is an alternative. The first study I'd like to review is the Astral-1 study, which was published in the New England Journal of Medicine back in 2015. This was a phase 3 randomized placebo-controlled trial using a fixed dose of sofosbuvir-velpatasvir for 12 weeks in treatment-naive and treatment-experienced patients with chronic HCV and genotypes 1, 2, 4, 5, or 6. The study took place at 81 sites across the United States, Europe, and Hong Kong. To be eligible, patients had to have chronic HCV and a genotype of 1, 2, 4, 5, or 6, as well as an HCV RNA greater than or equal to 10,000 at screening. Prior treatment failures with interferon were allowed, but participants could not have failed a prior NS5A or NS5B containing regimen. Participants with compensated cirrhosis were also included in the study, but patients with a history of hepatic decompensation or hepatocellular carcinoma were not eligible for enrollment. The primary endpoint was sustained virologic response 12 weeks after completing treatment. In total, 740 participants were randomized in a 5-to-1 ratio to receive treatment with daily sofosbuvir-velpatasvir versus placebo. Randomization was stratified by cirrhosis status and hepatitis C genotype. Because of the low prevalence of genotype 5 in the study regions, participants with genotype 5 did not undergo randomization but were assigned to the sofosbuvir-velpatasvir group. Demographics were well matched between the intervention and placebo arms. The average age of participants was 53 to 54 years of age. Over 3/4 were white and the majority had genotype 1, followed by genotypes 2 and 4. Average BMI was 26 to 27, and most had an HCV RNA greater than or equal to 800,000 at baseline. 19% of participants in the sofosbuvir-velpatasvir arm versus 18% in the placebo arm had compensated cirrhosis. The remainder did not have cirrhosis. In the sofosbuvir-velpatasvir arm, 32% had prior treatment experience with an interferon-based regimen versus 28% in the placebo arm. The most common prior therapy was pegylated interferon plus ribavirin, followed by pegylated interferon plus ribavirin and a first-generation protease inhibitor, and subsequently standard interferon with or without ribavirin. Among the 624 participants in the sofosbuvir-velpatasvir arm, 618 or 99% achieved an SVR12. The proportion achieving SVR12 was similar across genotypes, ranging from 97% to 100%. Having compensated cirrhosis or prior treatment experience had no impact on treatment efficacy, with 99% of participants achieving an SVR12 regardless of the presence of compensated cirrhosis or prior treatment experience. Serious adverse events were uncommon in this study, and less than 1% of participants who received sofosbuvir-velpatasvir discontinued the drug due to an adverse event. There was one death in the treatment arm that was unlikely to be related to study drug. Mild adverse events were relatively common in both the sofosbuvir-velpatasvir and placebo arms. Amongst those receiving sofosbuvir-velpatasvir, 29% experienced headache, 20% experienced fatigue, 13% had nasopharyngitis, and 12% had nausea. Laboratory adverse events were relatively uncommon. Collectively, the results of the Astral-1 trial showed that once-daily sofosbuvir-velpatasvir for 12 weeks provided high rates of sustained virologic response among both previously treated and untreated patients with chronic HCV, including those who had genotypes 1, 2, 4, 5, or 6, with or without compensated cirrhosis. The next study I'll review is the Astral-4 trial, also published in the New England Journal of Medicine back in 2015. Astral-4 was a phase 3 randomized open-label trial examining the safety and efficacy of a fixed-dose combination of sofosbuvir-velpatasvir for 12 weeks with or without ribavirin versus sofosbuvir-velpatasvir for 24 weeks in patients with HCV genotypes 1 through 6 and decompensated cirrhosis. The study took place at 47 sites across the United States. All participants had child Turcotte-Pugh Class B cirrhosis at screening, but 10% of participants had either Class A or Class C cirrhosis at treatment baseline, reflecting dynamic changes in the child Turcotte-Pugh scoring in this population. Prior treatment failure was allowed, except for prior treatment failures with an NS5A or NS5B containing regimen. Participants with a prior or impending liver transplantation were excluded, as were those with a platelet count less than 30,000 or a creatinine clearance less than 50. The primary outcome was sustained virologic response 12 weeks after treatment completion. Participants were randomized in a 1-to-1-to-1 fashion to receive either 12 weeks of sofosbuvir-velpatasvir or 12 weeks of sofosbuvir-velpatasvir plus weight-based ribavirin, or finally sofosbuvir-velpatasvir for 24 weeks. Approximately 90 participants were included in each arm, and the mean age across all arms was 58 years of age. The majority of participants were male, and most were white. Over 3/4 of participants had genotype 1, and the majority had an HCV RNA greater than or equal to 800,000 at baseline. Most participants had a child Turcotte-Pugh score of 7 to 9, reflecting the inclusion criteria of having Class B cirrhosis at screening. However, prior to treatment initiation, a small number of individuals had either Class A or Class C cirrhosis. MELD scores varied, but most participants had a MELD score between 10 and 15. Across arms, 47 to 64% of participants were treatment experienced, with most having received prior pegylated interferon plus ribavirin. Rates of sustained virologic response were 83% in participants who received sofosbuvir-velpatasvir for 12 weeks, 94% amongst those who received sofosbuvir-velpatasvir plus ribavirin for 12 weeks, and 86% amongst those who received sofosbuvir-velpatasvir for 24 weeks. The rate of sustained virologic response amongst participants with genotype 1 was overall high, with 88% of participants in the 12-week sofosbuvir-velpatasvir arm achieving a cure versus 96% in the sofosbuvir-velpatasvir plus ribavirin arm and 92% in the sofosbuvir-velpatasvir for 24-week arm. Rates of SVR12 were lowest amongst those with genotype 3, with only 50% of those who received sofosbuvir-velpatasvir without ribavirin, either for 12 or 24 weeks, achieving an SVR, versus 85% of those who received sofosbuvir-velpatasvir plus ribavirin for 12 weeks. All participants with HCV genotypes 2, 4, or 6 had a sustained virologic response, except for one patient with HCV genotype 2 who was assigned to receive sofosbuvir-velpatasvir for 24 weeks, but died of liver failure after completing 28 days of treatment. Of the 223 patients with a baseline MELD score of less than 15 for whom MELD data were available at post-treatment week 12, 51% had an improved MELD score, 22% had no change in the MELD score, and 27% had a worsening in their MELD score. Similarly, of the 27 participants who had a baseline MELD score of 15 or greater, 81% had an improvement in their MELD score following treatment, while 11% had no change in the MELD score and 7% had a worsening in their MELD. Serious adverse events occurred in 16 to 19% of participants across arms, with the most common serious adverse events being hepatic encephalopathy and sepsis. Despite this, treatment discontinuations because of adverse events were uncommon. The most common adverse events were fatigue, nausea, headache, anemia, diarrhea, insomnia, pruritus, muscle spasms, and dyspnea. In the two arms that did not receive ribavirin, 8 to 9% of participants experienced a hemoglobin less than 10, but by comparison, 23% in the sofosbuvir-velpatasvir plus ribavirin arm had a hemoglobin less than 10, which is consistent with ribavirin's known ability to cause hemolytic anemia. Collectively, the Astral-4 study demonstrated that treatment with sofosbuvir-velpatasvir with or without ribavirin for 12 weeks and with sofosbuvir-velpatasvir for 24 weeks resulted in overall high rates of sustained virologic response in participants with decompensated cirrhosis, with the highest rates of SVR being amongst those who received sofosbuvir-velpatasvir plus ribavirin for 12 weeks. The third study I'd like to discuss is the ACTG MIN-MON trial, which was published in the Lancet Gastroenterology Hepatology in 2022. The MIN-MON study, or Minimal Monitoring Study, was a Phase 4 open-label single-arm trial examining the safety and efficacy of a minimal monitoring approach to HCV care delivery using 12 weeks of sofosbuvir-velpatasvir in treatment-naive individuals. It took place across multiple sites in Brazil, South Africa, Thailand, Uganda, and the United States. To be eligible, participants had to have chronic HCV infection as determined by an HCV RNA greater than 1,000, be treatment naive, and be 18 years of age or older. HIV co-infection and compensated cirrhosis were both permitted, but individuals were excluded if they had HBV co-infection. The primary endpoint was sustained virologic response at least 12 weeks post-treatment completion. In this study, there were no pretreatment genotypes obtained, and cirrhosis was determined based on calculating a FIB-4 score. All treatment medications were provided at study entry, and there were no scheduled on-treatment visits or lab draws. Investigators checked in with participants by phone at weeks 4 and 22, and SVR12 labs were drawn at week 24, or at least 12 weeks following treatment completion. A total of 399 individuals were enrolled, with a median age of 47. 35% were female, 42% were white, 18% Black, and 28% Asian. 3% reported current injection drug use, and 40% reported current alcohol use. Only 9% had cirrhosis based on FIB-4, and 42% had HIV co-infection, with nearly all co-infected patients having a suppressed HIV viral load. Collectively, 95% of individuals in this study achieved an SVR, including 95% of those with Hep C monoinfection and 95% with HIV and Hep C co-infection. Among the 34 participants with cirrhosis, 88% achieved an SVR. Among the 365 participants without cirrhosis, SVR was achieved in 96% of participants. Current and prior substance use had no impact on SVR, with 95% of individuals with current substance use achieving an SVR versus 94% of those with prior substance use and 96% of those without a history of substance use. 4% of participants experienced a serious adverse event. Of the 14 serious adverse events, 5 occurred while on treatment, none were deemed to be associated with the study medications, and none resulted in treatment discontinuation. 3 participants reported losing their medications. 1 lost medications after 14 days on study and per protocol did not receive a replacement. The other 2 received replacement medications as they lost meds at day 4 and 7. Only 2 participants reported premature discontinuation of sofosbuvir-velpatasvir, 1 due to medication loss, as discussed previously, and the other due to a grade 1 adverse event. To conclude, amongst a diverse global population of people with hepatitis C, the Min-Mon approach with sofosbuvir-velpatasvir treatment was safe, and rates of SVR were comparable to standard monitoring observed in real-world data. Coupled with innovative case-finding strategies, this strategy could be crucial to the global hepatitis C elimination agenda. To learn more about hepatitis C, please check out our Hepatitis C online curriculum, which contains a variety of lessons, cases, and slides to reinforce your knowledge. Thanks for joining me today.
The production of this Hepatitis C online mini-lecture was supported by a cooperative agreement from the Centers for Disease Control and Prevention, CDC, RFA, PS 212105. This project is led by the University of Washington Infectious Diseases Education and Assessment Program.